ulnar nerve or the radial nerve. Radial nerve rarely. Radial nerve is rarely. Radial nerve usually comes with the there's a fracture of the humerus that causes injury to the radial nerve. That's why you have wrist drop, finger drop, and all that. Alright. Otherwise, the normal common degenerative conditions are like your carpal tunnel, pronator teres, or your claw hand. Okay. So I'll show you how to examine the hand. So, alright. So, on general inspection, patient is alert, comfortable, and not in pain. I do not see any orthopedic spin around the patient. On closer inspection, you supinate the hand first. You start with supination. So again, SWAD, there's no obvious swelling, no scar, no skin changes, and sinus. There is no. Usually then, I will go to deformity and attitude and alignment before wasting for hand. Okay, I'll tell you why. Okay, attitude and the alignment of the bilateral upper limbs appear to be normal. Okay, and there is good there's good hand cascade. Hand cascade is like this. Flexion, and like a staircase effect like that. Okay, alright. Those who have an extensor or flexor tendon injury, maybe their hand cascade is like this, or you have a fracture, then you will be malrotation. Okay, understand? This is a normal hand cascade. Alright. Only then I will mention wasting. Why? Because you check for thenar and hypothenar muscle wasting. How do you check that? This one, I'm looking at the thenar muscle. Thenar muscle means here. Okay, okay, you straighten up all your fingers. Okay, alright. Then I can see clearly and compare. There is no thenar muscle atrophy. How do you check for hypothenar? Yes, correct. You do this. Okay, you do this. Straight like this. I'm looking here for the hypothenar. Okay, alright. So like this, you mention everything else, but not the muscle atrophy. Then you ask the patient, there's no thenar muscle atrophy, there's no hypothenar muscle atrophy. Only then you ask the patient to turn prone. Okay, so pronator, what do you check? You check for muscle wasting again. Interosseous muscle guttering. There's no interosseous guttering. So if there's guttering here, they'll be very depressed here. Only they can see the tendon. Understand? They'll be depressed because of the muscle wasting. Then after that, you can mention there is the near changes, any dystrophic near changes. Okay? And is there any nodules or any swelling? Because they could have gouty tophi, they can have rheumatoid nodules, or they can have Herbert's node or Bouchard's node in osteoarthritis. Herbert's at the DIPJ, Bouchard's node at the PIPJ. Okay, so after that, you can check if, let's say, there's any gouty tophi, rheumatoid nodules. Immediately the next thing you check, ask the patient to do like this. You check for the rheumatoid nodules here or the gouty tophi here. Okay, understand? So that is for look. I wouldn't go to move straight away. So you see hand is a bit different. After you look, supinate, pronate, KIV elbow. Then after that, I'll ask the patient to move. Because feel will take time. You see, you want to feel so many things. It takes time. I'll ask the patient to move first. Move like this. This is radial deviation. This is ulnar deviation. This is wrist flexion. This is wrist extension. Okay, and then do you have a pen? Two pen. One more pen. Alright. So you ask the patient to hold the pen like this. Okay, alright. Now turn like this. This is for pronation. Then turn to the other side. Supination. If there's any change in the angle, differences, then you know that whether it's a limitation in the pronation or supination. Okay? So remember, these 6 motions are coming from the forearm. Coming from the wrist. Flexion, extension of the wrist, radial deviation of the wrist, ulnar deviation of the wrist, pronation and supination is coming from the wrist. Now we go to the 4 motion of the hand. So 10 motion. 4 motions of the hand. Now, can you do this? You flex all your fingers. So the patient, so how you comment is not like full finger flexion or what. Where does the patient touch? Distal palmar crease or proximal palmar crease? Proximal palmar crease or distal palmar crease? Usually at least a proximal palmar crease. So this is a distal palmar crease, this is a proximal palmar crease. See where they can touch. Finger flexion. And then finger extension. Okay, good. Now, can you twist turn? And then I'm going to ask you to cross your finger like that. Can you do that? This is abduction and adduction. Abduction and adduction. Okay, so 4 motion in your fingers here, and 6 motion at your wrist joint. So I do all this ready. If let's say it is like for example the stem is a 3.5 radial sided finger numbness, then I will do this OK sign for a screening test. Okay, so what does the each nerve supply in this movement? Okay, so basically the screening median nerve is this one. Median nerve allows you to flex your thumb, allows you to flex your index finger. This is median nerve. Allow you to do extension of the wrist, extension of the finger is called radial nerve. Allow you to open up like this is ulnar nerve. Okay, so this is a screening test. Okay, then when you do screening test, usually I will straight away go and do okay, you press. Then I will straight away go and test whether it's strong or not. Okay, alright. Good enough. Alright, so now for each nerve, you need to identify whether it's high lesion or low lesion. So there are 4 components. One is motor, one is sensory, one is Tinel sign, and one is special test. Usually my hand will go in this sequence. Okay, so let's say the stem is 3.5 radial sided finger weakness. So it could be carpal tunnel or it could be pronator teres. These 2. So high lesion, low lesion. Straight away go motor. Motor. You want to see high lesion or not? You check for FDP of the index finger. Okay, because FDP, the innervation is given off here. Okay, alright. So now bend your index finger. Don't let me pull it up. Okay, alright. This is to check the motor high lesion. Motor low lesion, how do you check? Abductor pollicis brevis, APB. You ask the patient to point towards the ceiling, okay, and you press it down. Press at the proximal phalanx at the radial aspect because your APB is attached here. Okay, you feel for the muscle here and then you ask the patient. This is for low lesion of median nerve. Okay, so again, flexion of the thumb is like this. Extension of the thumb is like this. Okay, adduction is like this. Adduction, adduction. Adduction is not like this, you know. Adduction is like this, and abduction is like this because your fingers and your thumb, the plane is different. This, the plane is like that. The thumb, the plane is like this. So the thumb punya flexion is actually towards this horizontal direction, and extension is like that. But finger flexion is like this, extension is like that. So this is A. So your finger adduction is in a horizontal plane, abduction in the horizontal plane. But when it comes to your thumb, the adduction is in a vertical plane. Adduction, then abduction. Okay, understand. So again, low lesion for median nerve, APB, you check. High lesion of median nerve, you check FDP of index finger. That's motor component. Sensory component, you check here at the tena eminence. Is it high lesion or low lesion? It's high lesion. Okay. If there is numbness here, it indicates that it's coming from here, pronator teres. It's high lesion. Okay. Why? Because the nerve is called a palmar-cutaneous branch of the median nerve. It branches off about 5 cm before your wrist crease. So it comes off here. Anything that affects the carpal tunnel will not affect this nerve. So it's a high lesion. Low lesion median nerve, sensory, where do you check? Fingertip. Index finger, fingertip. So motor, you got high lesion, low lesion. Sensory, you got high lesion, low lesion. Okay. Then you do Tinel sign. Tinel sign, just tap, and then the patient should feel the shooting sensation from carpal tunnel all the way to the pronator teres. Okay. All right. So now special test. Special test for these 2. Okay. There are so many special tests for carpal tunnel. You have Durkan compression, you've got a Phalen test, reverse Phalen test. I just do one, enough already. Okay? But you need to know all, how to do, but you don't have to perform all. Durkan compression test, you use your thumb, not other thing, thumb, press on the carpal tunnel. Carpal tunnel is not here, carpal tunnel is here. Okay? You press on the carpal tunnel for how many seconds? 30 seconds. Durkan compression test is 30 seconds and it is the most sensitive or specific test. Sensitive test, alright. Now what is the most specific test for carpal tunnel? No, it's actually a hand diagram. The hand diagram, you can go back and read out about it. You ask the patient to draw where's the numbness and all that. So that diagram is the most specific test for carpal tunnel. Sensitive is Durkan compression. Okay, let's say if you ask the patient to do a Phalen test. Okay, alright. How many seconds? 60 seconds. Okay, Phalen test is 60 seconds, Durkan compression is 30 seconds. Okay, alright. So just one special test. Usually I just do Durkan because it's 30 seconds only. Okay, alright. Then after that, the special test for pronator teres, what are the three? This is a bit difficult. Okay, this is a bit difficult because you need to know what are the 5 areas that can compress on your pronator, that can cause pronator syndrome. One is ligament of Strutter, one is supracondylar process, but those two cannot be checked. Okay, go back and read out about pronator teres. Okay, the other 3 you can just write down now so that you know what I'm checking. The other 3, one is a FDS arch, flexor deltoides superficialis arch, FDS arch. Okay. The other one is your bicipital aponeurosis. Okay, and then the third one is between the 2 heads of the pronator teres. On top of those 2, so 5 altogether, 5 sites of compression. One is ligament of Strutter, which is here. The second one is the supracondylar process, also here. These 2 cannot check. And it's only present in about 1% of the population, the ligament of Strutter. So no need to check. The other 3 are here. Okay, so the other 3 are here. Bicipital aponeurosis is a bicipital tendon, isn't it? So how do you check? You ask the patient to flex against resistance. Okay, flex your elbow. Do have the patient feel pain here. Okay, that means that the compression is at the bicipital aponeurosis. Okay, now you ask the patient to pronate against resistance. Try to turn in, and the patient feel pain here. Pronator, because between the 2 heads of the pronator teres. The last one, FDS arch. You ask the patient to flex the finger against resistance. Then, if it is positive here, the pronator, the compression site is at the FDS arch. Okay? So, 5 areas of compression for pronator syndrome, but only 3 you can check. And you go according to the function. Bicipital, then you check the biceps. FDS arch, you flex the finger. Pronator teres, you pronate the forearm. That's all. Okay? So from these 4 things, motor, high and low, sensory, high and low, Tinel sign, and special test, you know this patient is whether having a carpal tunnel syndrome or a pronator teres syndrome. Okay, alright. Now, ulnar nerve. Okay? Alright. So the same thing, everything the same. Look, feel, and then look, move, and then after that you go to the ulnar nerve. So ulnar nerve, motor first. High lesion. Okay, high lesion, you check for, you ask the patient to flex the little finger, don't let me open up. So you remember median nerve, we check this one, the high lesion, FDP of the index finger. Now we check FDP of the little finger. That's high lesion ulnar nerve. Okay, so if the patient that there is weakness, okay, it's called Pollock sign positive. Heard before? Pollock. If there is weakness of the FDP of the little finger, it's called Pollock sign positive. And Pollock sign positive is an ulnar nerve palsy. Okay, and it indicates a high lesion. That's high. What is low? Low motor for ulnar nerve. AB. Abduction, adduction. Again, if you want to confirm, you can ask the patient to do again. Abduction and abduction. That's low lesion. They won't be able to do. They will, one side, normal one, they will do like this. The other normal one, they will do like that. Very big. Okay? That's low lesion for ulnar nerve. Sensory for ulnar nerve. Low lesion, where do you check? Tip of the little finger. You just check here. Tip of the little finger. Okay? Why don't you check at the ring finger?
Mix.
Correct. Very good. Okay. If it is high lesion on the ulnar nerve, where do you check sensory? Here. The dorsal ulnar hand. Okay, because the nerve, it branches off here. and supplies it. Okay, that's a high lesion of ulnar nerve. So low lesion, high lesion. Then motor got high lesion, low lesion. Then inner side, tap along the ulnar nerve. So high lesion, low lesion is called a Guyon canal, or ulnar tunnel syndrome. High lesion is called a cubital tunnel syndrome. Okay, just now we have carpal tunnel and pronator syndrome. Now we have Guyon canal or ulnar tunnel syndrome, and we have a cubital tunnel syndrome. So thinner side. Now special test. What is a special test for low lesion for ulnar nerve? Heard about Froment sign before? Yes. Okay, so what is Froment sign? Correct. Yeah. Grab a paper, ask the patient to close like that. Don't let me put it up. Alright? And then this is what motion is that called? Adduction, right? Adductor pollicis is supplied by your ulnar nerve. So if your ulnar nerve is okay, they would be able to do that. If they cannot, how do they compensate? They will go like that. They'll go like that. Why? Because they will use their median nerve that flex the thumb. That's called a Froment sign positive. Okay, that's a special test for low lesion. Froment sign. High lesion? High lesion also nothing. High lesion is just you press on the cubital tunnel compression, and then it causes pain. Then after that, you can feel the ulnar nerve. Let me feel your ulnar nerve. This is your medial epicondyle. So usually it's behind the medial epicondyle. This is your ulnar nerve. You can hear, no shooting sensation. Okay, alright, this is your ulnar nerve. So you flex and extend the elbow. See whether the nerve subluxate anteriorly or not. It should be behind. If you flex and extend, tiba-tiba the nerve come out, come down, go up, go down, go up, go down like that. That means that there is ulnar nerve instability at the elbow. And when you do operation, you're going to fix it to one point, usually anteriorly. So for cubital tunnel, it's just you press on the cubital tunnel compression test, and then you check for the ulnar nerve stability. Okay, alright. For radial nerve sensation is just here only. Okay, there is no, because sensory, radial nerve only supplies here. This is the only area. So high lesion, low lesion is going to give problems to this area. First dorsal web space. Okay, and then after that, very high lesion is here, right? A very high lesion, low lesion, high lesion, low lesion. High lesion, if here, you won't be able to extend your elbow. Tricep will be weak. Understand? And then, if low lesion, the motor power, you won't be able to extend the wrist, you won't be able to extend the finger. So try to extend the wrist, don't let me push it down. Okay? And then extend all your finger, don't let me push it down. It's freedom. That's all. High lesion, low lesion. Sensory here. Special test? No. Thinner sign, if there's any injury, you can tap along the radial nerve and they can feel the shooting sensation. But like I said, radial nerve very rarely, unless it's a trauma case, patient got a fracture of the humerus that tear the radial nerve, then yes. Otherwise, it's just median and ulnar. Okay, now this one also a lot of information. You need to go back and digest. High lesion, low lesion. Okay, alright. Now, sometimes just end of the examination, they might ask you, because sometimes cervical can give you the same problem also. C5, C6 also numb here, right? So how do you differentiate it from a peripheral nerve from a cervical pathology?
Reflex.
Correct. Reflex and your power. Power of what? Power of elbow flexion, elbow extension, and this one. Because most likely you could have C6, C7 pathology that can mimic median nerve. C6, C7. So C6, C7, how do you do? This one is C6, this one is C7. If it is median nerve, this won't be weak, this won't be weak. Okay? Then after that, you check the reflex of C6 and C7. C6 here, C6 here, C7 here. There could be some hyperreflex here. Alright? So, sensory won't be able to tell you much because median nerve, they will feel numb here, they will feel numb here, C6, C7 also numb here. So, power of your elbow and wrist as well as your reflex. Okay, that's for cervical. Alright. For ulnar nerve, C8 and T1 can mimic C8 and T1. Okay. Sensory, T1 here. Alright. So if the sensation is lost here, then most likely cervical, because ulnar nerve is just here and here. Understand? Okay. So likely from here. And then motto of the C8 and T1, difficult to check because ulnar nerve also do this, T1 also do this. C8 do finger flexion, and then ulnar nerve also do this. Quite difficult. So sensory. Okay. Another pathology that can come together with this one that can reproduce the same symptoms also is called thoracic outlet syndrome. Heard before? So thoracic outlet syndrome, there are 3 different tests that you can do. Okay, now this is the last part of our session today lah. Quite a lot already. Okay, so thoracic outlet, you stand up. There are 3 tests that you can do. Okay, face there. So let's say the patient has got a pathology here. Numbness, weakness, you already rule out peripheral nerve, you already rule out some cervical pathology, but you're not sure whether it's a thoracic outlet. So 3 tests. The first test is called Adson's test, A-D-S-O-N. You palpate the radial pulse here, okay? And then after that, ask the patient to look here, and then take in a deep breath. During the deep breath, there is a reduce in the amplitude or the volume of your radius pulse or absent radial pulse. That means that there is a thoracic outlet syndrome. Adson's test. This is Adson's test. Okay, alright. Now, Wright hyperabduction test. This is what I write. Wright hyperabduction test. Okay? Again, you palpate the radial pulse here. You extend the shoulder, externally rotate the shoulder. Ask the patient to look towards the contralateral side, left hand side. Okay? This maneuver causes reduction in the volume of the radial pulse. This is called a Wright hyperabduction test. Again, indicates there's a thoracic outlet syndrome. Okay? Now, last one. Roos test. R-O-O-S. R-O-O apostrophe S. Roos test. How you do Roos test? It's also called a elevated arm stress test. E-A-S-T. Okay? How do you do? Elevated arm. Okay? Roos test is like this. You shoulder abduct 90, elbow flex 90. Ask the patient to gently open and close, open and close, open and close for 3 minutes. Okay? And it will produce that kind of numbness and weakness in your upper lip. So 3 tests for thoracic outlet. Okay? Alright? So Adson's test towards the ipsilateral side, deep breath. Radial pulse gone or reduced amplitude or reduced volume. Then Wright hyperabduction test, extend, externally rotate, look towards the opposite side. Roos test, this one, 3 minutes. These are the 3 tests. Most of the time, you wouldn't even have time to rule out all this pathology, but in case they ask, what else can we make? And then how do you want to tell? Then you need to know. By just verbally or demonstrate to me. Usually it will come in such a way. Okay? So, you see, all these nerves are pointing towards the same direction of your pathology, except Wright hyperabduction test, you look towards the contralateral side. Spurling test, same side. Adson's test, same side. Okay? Alright? Alright. So, any question?